First of all, I would like to welcome our attending listeners and audience to our interview regarding the common advices, for example, for physiotherapists in treating COVID-19 risk patients. My name is Andreas Rucker, and I'm head of the Product Management and Development Department at Proximed. And I appreciate very much to have Professor Dr. Andry Vleeming as a clinician, researcher, anatomist, and biomechanist with international reputation ready for an interview to our present coronavirus. Thank you, Andry, to be ready for this interview.
You're welcome. You're welcome.
First of all, I would like to introduce you a little bit to the audience. Several years ago, you have mentioned that you have a personal first success in your life, and that was to publish a book named in the German-speaking countries Nicht-operative Orthopädie und Manualtherapie, which you have published in 1987. Maybe you can say something about this topic?
1987 is very far. But no, that is actually, I was definitely not alone. I was working in a very positive way with Dos Winkel, and he was actually starting already the textbooks, what we're talking about, the nicht-operative Sachen from that book. And I didn't know, we knew each other very well, but I was busy with something that was really necessary in medicine, in other things, to properly understand, to treat patients, but then to find out where are my hands, where is the anatomy in vivo, which up to this day is still a problem with patients and doctors and therapists, because it's a necessity to do it properly well. Why? Because basically every pain point that we have in our body is in one very specific thing that has a name. It's never random. But if you don't know in a proper way, if you don't find out with anatomy in vivo, where are we? What are we doing? Where's your pain from? Maybe it's a pain issue, and it's maybe reflecting somewhere else, but there's always one point. So that was the start for something that I didn't understand from so many colleagues. Okay, we don't know what is happening on your body. Well, then we have to work on it and properly work on it to try to find out what are we actually doing. That was the book of Anatomy in Vivo. Then I met, actually, we met already as friends, and he started the second book. I had a little part there, a third book, a little part, and then there was a book about SIJ, sacroiliac joint book in that time. And very, very strange. We worked hard on the book. We would be happy that some people wanted to read it, but it was the strangest thing. It went all over Europe, up to England and Germany, and we never had that idea. So yeah, it was a good start.
Great. By the way, I have ordered it, a used one, and I hope to get it today, but it is not yet here. At present, the Department of Anatomy of the University of New England in Biddeford, Maine, USA, you are working. You are a part of Professor Dr. Andry Vleeming in the Rehabilitation Department of Ghent University in Belgium. You founded clinical scientific research team at Erasmus University in Rotterdam. Next to numerous publications, you have 59 peer-reviewed articles published in leading musculoskeletal journals. You have published 15 books, which you have mentioned, just one of them, and you are editor of 20 books and 18 book chapters. I have met you as a scientific committee and the chairman of the Interdisciplinary World Congress of Low Back Pain and Pelvic Girdle Pain. Yeah, this is a long CV.
Yeah. Yes.
Most likely, I like to point out that you are not only in the university level as a professor working in research and education, but also you always want to have the contact to the physiotherapists and sports scientists, sports therapists, as you do in Berlin and in Zurich, and you have done also in April last year in China to give direct workshops.
Yeah, correct. Yeah. Yeah.
The interview is now to focus on the topics regarding the pandemic situation of the coronavirus related to your expertise, which is for sure interesting for the physiotherapist, maybe rehabilitation doctors and athletic trainer. How it feels now for you when knowing you since 2007, that you are not able to fly to Boston or Melbourne anymore to push forward and talk to your colleagues?
Well, the good thing is that we all are in the same situation. So we can't come up with all kinds of ideas. Oh, I'm so sad because we can't do this. Congresses from colleagues not so far away in March. Really in Dubai to do it, and it didn't work. And then all the other congresses who came later, the same situation. So that was really, really a bad thing. And you see now that some of these organizations are going now to 2023 or 24 because they have a rotation of 3 or 4 years. And yeah, it's a shock for everyone. But definitely, I'm not a COVID specialist, but from traveling and understanding what is happening, there's one clear thing. You see in Taiwan, and that is one of the places where I want to go, September, October, or a little bit later, that in Taiwan, with 31 million people, there are hardly any patients. People have been very careful. The same, which is quite specific, in South Korea, with a lot of people, but they did their work really needed. What is the need? To have proper prevention with a cap when people are talking together, but it doesn't matter if I'm talking to you with a cap on my face, then what is happening, that's not good enough. Well, you're safe now, that's for sure. But I mean, it's the situation to understand, and probably in 2 weeks, what is going to happen in Europe, that we get more freedom. But you can only do this freedom, to get this freedom, without a proper right. on right. your face. And it doesn't help if you talk to me or the other one. It should be for 2 things. Why are people proud in Asian countries with that? Because they prevent from themselves that they don't do something to you, and on the same time you prevent the other one. So if you are in 2 or 3 weeks, and this is really going to happen, then you have to see that if we are 2 meters away, 1.5 is a little bit not so much. If someone have coughing or even something with the nose, it can go for 6 meters. So actually, it's the reality. And so 2 meters apart, and it doesn't work if one has a cap and the other one doesn't have a cap. And that is what is happening in Taiwan, South Korea, and parts in China.
Yeah, that's correct. But nevertheless, I mentioned Melbourne especially. Paul Hodges is one of your partner and research in the research team. And last year, as far as I remember, you have been in Australia quite often or for a long time to push things forward in the research development. Correct?
Yeah, that was the time when I met Paul Hodges, and if I'm right, somewhere we were, if I do that well, 2007, I think we were in Vienna. Or maybe earlier he was there. He was just a student, a very good student, fantastic student, a lovely guy. And from then on, he has been working with us with the World Congress. And we see each other in other congresses in the world. Yeah, that's Paul. Yeah.
You mentioned already in the first question, but as a researcher, you are most likely also interested in the articles of SARS-CoV-2 or COVID-19 diseases. Do you, one of your conclusion is if everyone in Europe would behave like in Asia to wear caps, but you have anything else to add to this, that you have some papers, studies which are remarkable for you?
No, because I'm not a virologist.
Yes.
And we see every night, everywhere in the world, we see how people are trying to find something better all the time. Sometimes it succeeds. Sometimes you do something for the next day which is really wrong. That happens. But that is understandable. Everyone in the world is trying to do their best. But overall, Europe and probably also America and the rest of the world, if we will get the freedom, and the freedom will come in Europe, in Germany, in many, many countries, things are getting better. But what is the prime thing to do again and again and again? What we learned from Asia. I can talk to you, you can talk to me, we need a cap.
Yeah.
And we need few caps. A lot of caps, because you have to throw them away. And another thing is there, you have to be very careful if you don't understand what is happening. There is your cap. You put your cap on your face, you have the elastics on your head, and that cap, you shouldn't use that to your mouth, your nose, or your eyes. So people, you have to tell the people, because now they have been taught that, okay, don't go to your face. Well, if you have the cap on and you come to your eyes and your nose, you have a problem. So first of all, you wash your hands in a proper way, maybe 20 seconds in a proper way, and then your hands, after that you can take a cream, and then you can use that and get it on your head, but definitely not on eyes, nose, or mouth.
Yeah. Thank you.
And
you often talk about your severest patient groups coming in wheelchairs due to massive pain in the pelvic area, pelvic girdle area, and low back pain. As far as I remember, the main aspect of the positive results of this treatment is activity and focused training. Can you maybe describe a little bit?
What happened? I was working with very good people in the Erasmus University. I was teaching. We had a very good place to do work in biomechanics, with orthopedics, physical therapists, all working together. And it was a fantastic thing. But sometimes, once a year, women would come from Germany, from Denmark, from Norway, from other countries, to come in the evening of Erasmus University to our part. And they wanted to hear what we were doing. And I was doing already from 1988 to try to understand the most important thing in the body, which is the pelvis, because we have the pelvis, we have levers, that is this, we have our legs are the levers, but the base of our body is the pelvis. And everything that's happening in the spine is coming from up here, has to go down to sacrum. Where is it going then? Well, not in the abyss. It's the law of Newton, the third Newton. There is a reaction and an anti-reaction, meaning that all our weight goes from the sacrum into the legs and then comes back again. So therefore, I was really mesmerized to understand why that pelvis is doing what it was, why that pelvis is a little bit different from women and from women. And that is what we have been doing. And it took a long time to try to be a little bit right. We, over 7 years, with support from very good people, like Professor Snijders and other people. And that was the start. The people, women especially, came and they wanted to learn what was happening. And finally, when I came out of the hospital one of the days, they said, why don't you start a hospital? And that was the rarest idea I ever heard. I thought, I'm very happy where I am. I'm happy with my friends and my colleagues. Why should I start a hospital? I don't have a hospital. But they pushed, and in the end, for a very strange brainwave, again, I found good people, very good orthopedic people, very good physical, rehabilitation people, and we started a rehabilitation center. That was rare, because since 1892 in Holland, there was never a completely new hospital. They don't need it because in 1950, 1960, you have a hospital. You don't need another one. You lengthen it, you make it bigger. From 1892, there was no one else starting a hospital, and we started a hospital. And it was a very harsh thing to work with politicians and to get it right. But we were running basically 1 year after the decision, and the doors went open in the rehabilitation center, and we started with 9 o'clock. It was the best people around us, and it never stopped. It was full on, and it became bigger and bigger and larger, and even now in the hand of another director, Jan-Paul van Lingerde, is now in Rotterdam with that center in the Rotterdam, and it's grown 2 times bigger, which is, I'm very happy for that it is still going on. I'm very happy for that.
Yeah, and the patients are also happy finally at the end, very much.
Yes, but I really have to say something about that. People have been trying with these patients to get them right, but they used levers. So there's the patient. The patient is very weak. The spine is very weak. The legs are very weak. And now there are certain people and certain very bad strength in your legs. And now on the lever of the legs, we are going to use your legs to get stronger. That was the biggest mistake. You have to go to core, and the core is the pelvis where the pain is coming from. And the worst thing you could do is ask someone who has lost basically 90% of extension power and rotation power in the spine. So anyone before was trying to use with levers. You can't do it. You have to go to core. And that is what we try to do. And it worked out actually really, really well. We were in the hundreds of disabled, especially women, disabled women who really tried. And psychologists, other people said to these women, well, it's a little, what can we say? Well, these people, these fantastic patients, They worked very hard, 2-3 months, came out of the wheelchair, got stronger because they lost their strength. So from an average age of a 33-year woman, let's talk about women, then you see they lost 90% of the extension power and 90% of rotation power. Okay, that happened. And in 3 months, instead of 5-6 years, when they were with a conundrum to get out of this misery, average age of the women 33, they could get out in 2-3 months and become normal. It was strength.
Wow.
Yeah.
And you proved this also in 2008 with your colleague Ron Chetty.
Ron Chetty was we did that together. It was a complicated study. We found out we took around 500 women, average age 33 years old, really impaired, and we wanted to see how bad it was. What is your strength? What is over of you? And we found out from these 500 people that was too much. So we found the group who was the deepest into trouble with their strengths. And we ended up with a proper number. It was 100. It could have been 100. And with the 100 patients, we've been looking. What was the conclusion? Rotation power, 90% lost. Extension power, 19% lost. And then we started actually with equipment really from your department, with Proxumed. Already we were working with that. And the 90% came back by training. So this is the same. Let's not talk about women. If you sit too much, if you don't walk too much, you lose so much. And the only way to get back for, let's say, not pelvic girdle patients, but males, other people, if we're getting very weak, we have to build up. And that's the same situation in the back. In the back, fascia, thoracolumbar fascia. In the fascia thoracolumbar, there are all these muscles. And you know that actually the multifidi we have, that most of the patients have a working external multifidus, the deeper one of the multifidus, which is doing the compression, is completely, if I may use the term, pulpy. Pulpy, that's fat there. You can see it on an MRI. Every MRI you see, the deeper part is doing nothing. Well, that is the stiffener. And that is what we have to bring back. And that is what I've been doing with lever nails, especially lever nails, that the deeper part can come back, but you need proper training for the deeper part of the multifidi. And that is in patients, they only do something with the external multifidi, and the deeper ones don't work.
Yeah. And I mix up the ranking of the questions, but today's situation of the inactivity is leading exactly to that problem, that there is a lack of movement, a lack of activities, maybe also specific exercises, and the problem at present is becoming stronger and stronger.
Yeah.
Okay. Thank you for this very precise, deep question. Thank you for sharing this knowledge. Coming to the risk group of getting diseases, COVID-19. Main articles and podcasts of German virologists often mention that not only the elderly people, but also the specific pathology groups have a big risk of severe courses of diseases. Is there a special remark from your side? Do you like to give?
We see, but we are not virologists, but we see for every input we get is that if you have someone who in one way or another is not so healthy, we're not talking about a group higher than 70 years, let's say at 70 years, but randomly, fortunately, really fortunately, there are not many people dying, but there are people dying. And then there is a cause. And the cause is there is maybe a lung problem already on its own. There is already a heart issue and another one maybe in the brain or somewhere else in the body. So if that comes together with younger people, then they are weak, and that's a problem.
Yeah.
And fortunately, we have to say that, fortunately for babies, for children, most of the time, everything is still good. Children can handle it. This is the opposition of the terrible flu in Spanish times when the kids were dying. This is fortunately not the case.
Yeah, that's true. And meanwhile, we discuss also with the physiotherapists and customers in the German-spoken countries that the respiratory therapy becomes very important out of training, out of building up again the function. Sitting all the day like this, maybe a severe patient who's lying in bed for a long time. Is there a special remark what to take care in the respiratory therapy from your side, from as a specialist from the trunk, pelvic, and spine?
Yeah, well, first of all, if we go back when we see people talking on television, you will see something. Just to start, and tonight you're going to look on the journal, on the television, and people are talking. What do you see? Their thorax comes high, they fix the thorax, they are breathing, and they talk a little bit, and then they are breathing, the thorax. Most of the people in nervousness, in one way or another, it's thoracic breathing. But you need to know, with thoracic breathing, you only ventilate roughly around 40%. It costs you a lot of work because your muscles are working. But now, because of this type of breathing, you compress your acromioclavicular joint. You are pressing the shoulders here to each other, and you get pain in your shoulder. So it's, look at television, look tonight when people are talking, and that's the case. So for the patients, for the severe patients, and we talk about back pain or pelvic pain, we never start with a patient who's breathing in the thorax. And maybe I can say a little bit about that. It's especially important to understand that women have a ratio between males and females from 1 to 3 for men to do this breathing pattern, but women can climb up from 3 to 7. So women are much more sensitive in breathing into the chest. And then the worst thing is your CO2 is getting lesser. With the CO2, the calcium disappeared in the body, and then you have a real big conundrum and you don't feel well at all. So it's very strange to see that even experts are talking, and you see that they're breathing and they do this and they snap a little bit of air and they do a little bit more. We should be breathing with our diaphragm because it costs anything. It's the big, in Latin, cupula. It's the biggest thing we have, the biggest muscle, and only it has to do one thing: activate your diaphragm, realize that your pericard of the heart is hanging on the top of the diaphragm. Diaphragm is going down, pulling on the pericard of the heart, so actually squeezing the heart with that, and now you get 100%. And it's very easy. But most of the patients we see, we have to start and to say, we we're not going to treat your pelvis. We're not going to treat your spine. We first of all take away this breathing here on this level, because you're compressing your shoulder, and there is a solution which is 100% very soft. A massive structure is the diaphragm. It pushes down, it comes into your intestines, and you let go, and that is all for free.
Great, thank you. Yeah, the diaphragm, the Zwerchfell.
Yeah.
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 Okay, perfect. I come slowly to the end of the interview, and you might give maybe also to the people sitting every day in quarantine or in restriction motion, what kind of secrets you have in your family is the same situation, and you have a specific exercise which you advise to everyone to do. This is important.
Well, for the situation right now, I think we should be very happy that people who are not binded, like all the people who can't do anything, but even when they are restricted, as older people, if they can move, doesn't matter, 3 times a day, and there is time. But now is the problem with the elder people. They do not have COVID, but they have to be protected. And if they get in contact with the other people, there is a problem, a real problem. So there are so many people now in the world, which is really sad, who really want to be by their loved ones, and it's not possible. What they have to do is to stand up, to sit up, to stand up, and go a little bit through your knee, do proper breathing here in your belly, which will help really with CO2 and O2. And at least if your room is small, move and do little exercises and do proper breathing.
Perfect.
That is what they can do.
Thank you. I appreciate so much that you did take your valuable time to give this interview. I liked it very much. And I wish you, Andry, and your wife and family important, healthy, and to meet very soon again by video or by a present meeting, and to see you on one of the congresses or in real time. Thank you.
Very kind of you for doing all this and making time. And I'm very happy that we can talk, and thank you very much. Okay, bye-bye.
Thank you. Bye-bye.